where we've seen a great deal of opportunities and potential. A lot of the work in computer science came in computer vision, and things like ImageNet made it so that these pre-trained networks allowed people to very quickly develop AI tools for a variety of tasks, and applications to medicine is a natural extension of some of those areas. And certainly in the areas of medicine where we have a lot of imaging, such as radiology and cardiology and pathology, we've seen great interest in the use of AI in these areas. One area that was mentioned is ophthalmology. Again, a lot of the first large-scale studies of AI in medical imaging was in ophthalmology in diabetic retinopathy. Since that first study, we've seen a continued push of applying AI to many clinical problems in ophthalmology. As was mentioned, the first completely autonomous AI system, at least approved in the FDA, by the FDA in the US, is for diabetic retinopathy. And this is a question that will continue to be discussed, is what do we as a community think of autonomous AI in medicine? But in the context of this, which is the use case that they're being considering for diabetic retinopathy, it seems like a good potential application. We've done a lot of work ourselves in the use of AI in ophthalmology, specifically in this disease called retinopathy of prematurity, which is one of the leading causes of preventable blindness worldwide, caused in often seen in premature babies. Another area that we've, again, related to medical imaging that was mentioned is radiation oncology. This, again, a lot of excitement for AI in radiation oncology, because contouring of tumors and organs at risk is a very time-consuming task. And there's also some variability among clinicians that we've seen studied a lot. And segmentation is really a really good application area for AI. Segmentation algorithms work pretty well. And then there's also the question of explainability is a little less key here, in the sense that you can see the output of the segmentation algorithm, you can see if it is correct, you can edit it. And so this can be a really good help in the workflow of a radiation oncologist or dosimetrist in terms of segmenting both tumors and organs at risk, especially. And I think we are already seeing this, and we'll continue to see a lot of this both in the research domain as well as in the commercial domain, is the use of AI for segmenting of organs. Digital microscopy is another area, again, because of the medical imaging type of background, and where we have 2D, often we have 2D color images, so a lot of the same applications from computer vision can be very easily applied here. And of course, the focus of the session being radiology, we've heard a lot from the previous speakers in terms of that, in terms of how we can use radiology for AI and radiology for so many different things. As one of the previous speakers mentioned, a lot of what we see in terms of radiology applications for AI has come about because of some of these large public data sets that have been made available, whether by RSNA through their challenges. So the bone age was an example of that. Pneumonia detection was another example, the SIM pneumothorax challenges. So anytime we have large public data sets available, very soon after that, we see the development of a lot of different AI solutions for that problem. So that's, again, a request to somehow, as a community, think about how we can foster this sort of development by making available either large centrally hosted data sets like RSNA has done for the challenges, or, as was mentioned, the question of federated learning. How do we set up these networks of federated learning where we can, again, learn across multi-institutional data without necessarily having to share the data? We've seen AI in many parts of the radiology workflows. So we've seen the proposal for using AI in protocoling, in sort of deciding what sequences to acquire, how best to acquire them. So smart scanners, in a sense. We've spoken very little about the reconstruction, although the previous speaker did mention that as well. And then, of course, a bulk of the publications has been, as well as the applications to the FDA and other regulatory organizations, has been in the last, the rightmost part of this, which is the clinical read. But all of these areas, again, have a lot of potential. And depending on the appetite for risk and appetite for a variety of things, some of these might be easier to get started with in terms of that as well. So just a very brief example of the reconstruction. This is work done from some colleagues at our institution, where they looked at how best to reconstruct MR data from case phase. And they showed that you can essentially get better SNR or better, starting with undersampled case-based data, you can get much better quality images. So this can be used to either reduce the acquisition time or improve the SNR and the quality, or actually reduce the contrast dose. We've seen this in the PET domain as well. So all of these have great potential in the reconstruction space. And I think we'll start to see much more of the AI going more upstream, as has been mentioned. So the one thing I'd like to note is that it's getting really, really easy these days to create AI algorithms. Auto ML and tools like that make it so that clinicians who have access to data, for instance, can, without coding, create an algorithm that seems to work quite well. A lot of the advances that we see in computer science in terms of the algorithm development, auto ML, are making it much easier for folk who are not necessarily deep learning scientists to start to develop algorithms that seem to work well. However, there's a lot of challenges in going from having an algorithm that works in a small data set or even a large data set to something that is robust and ready to be deployed broadly. So, I mean, we could envision a future not that far away. I mean, we have all of these pieces in a sense where we have annotations, we have data, we can have some of these automated methods, you get an algorithm, you have a different AI algorithm that does summarization, and we've seen that this wonderful paper where this abstract was written by the AI, and we heard a lot of the interest in structured reporting previously, so we can also see where we now can have a completely automated structured report come out of this. However, despite all that excitement, and I'm sure we'll make a lot of progress there, it is still quite difficult to create an AI algorithm that is broad and general and robust, that's unbiased, fair, self-aware in a sense. This is a slide from Dr. Keith Trier at our institution. He's presented it at the ACR and other places, where if you think about what a radiologist does, it's not just they're not just a nodule detector or a pneumonia detector. They have to read the whole study. So you actually are, a lot of what we've seen is these tiny, tiny boxes within this entire grid. So if you think of different modalities, you think of different anatomies, you think of different imaging, we think of different findings. And if you think about, for instance, doing MSK, MR of the knee, all we're looking at is this tiny sliver of the space here. And within that, for instance, you might have an algorithm that does a PCL tear. So thinking about where we are, which is a very narrow space, relative to what a radiologist does, which is reading the entire study, we really quickly appreciate how far we have to still go in terms of being able to do essentially what a radiologist is doing. So, oops. And then the narrower, in order to build robustness, often we end up becoming narrower, and then we think about making this grid even having more components. So something to think about while, as computer scientists and people developing the algorithms, we are excited about solving these very narrow problems, which can be extremely useful, but in the scheme of what we need to do in order to make an impact more broadly, we need to think about a much broader space. One of the challenges of deep learning is that these methods can be brittle. This is a study that seemed to suggest that these models don't generalize well, very few of the published studies actually have external validation. And there's a number of reasons why the models don't necessarily work as well on external data sets. There's many different hierarchies that have been proposed, similar to the levels of evidence that what one might see. Obviously, in RCT would be the best case. But very often what we see, even in publications, is that they don't have the external validation. They may be cross-validation with internally, or maybe a single test set, but very, very few of the publications have external validation, multi-site, especially multi-site data. Some of the types of heterogeneity that we see include the heterogeneity coming from the prevalence of the disease, for instance, or the fact that you might be using different scanners. When you have different scanners, the images can look quite different, and the algorithm developed on one system may not necessarily work as well on external data set. Here's an example of that. So this was a mammography data from the DEMIS trial, which is a mammography trial. We developed an algorithm for breast density. And you can see right away that the histogram of the intensities coming from the different scanners looks quite different. So when we train an algorithm on scanner 1 and test it on scanner 1, it works well. But when we train it on scanner 1 and test it on scanner 3, the algorithm performance drops tremendously. This is the kappa right here that we're showing. And you can see on the diagonal elements, which is training and testing on the same type of data, the algorithm works really well. But on off diagonal elements, the algorithm really does not work well. Interestingly enough, when we look at the like a t-SNE of the model of the data through the model, what we see if we have a data set that has all three different scanners is that the model has actually learned each of the individual data sets separately first, and then within each data set, it has learned to classify accordingly. So it's not that the deep learning model, even though it saw all of these different scanner types, actually did normalization of those. It maintained the separation of the data sets throughout the network. As mentioned, we can have a central database, and there's been many examples of that where everybody puts the data together, and that allows you to build more robust models. And if you have that, we can see as a bottom row that the algorithm performed really well on all data sets because it had, during the training process, seen all of those data sets. A different example of that is collaborative learning, and this is something that we are very actively working on and very excited about. Here, the idea being that you can have data within institutional firewalls. You don't have to put data out. You can continue to learn in a collaborative way using federated learning or cyclical weight transfer, split learning. There's a number of different technical approaches, but in all cases, they allow you to learn from data at behind institutional firewalls in a privacy-preserving fashion. This question had been brought up previously, the question of rater heterogeneity. So for instance, we have data from multiple raters in classifying a disease severity as indicated by the color code. And so this is 8 different raters, there's 34 different images. And what we see is that the threshold between sort of mild and moderate or moderate and severe is quite different for different people. For this person, it's like right here. For a different person, it's right here. And so this leads to what we typically see in the sort of ROC curves when we plot the rater performance, is that some raters are more sensitive and others are more specific. And now when you think about training an algorithm with data that has not been annotated by everybody, but rather by a single person, and you're mixing data that might be coming from a person here versus a person here, it leads to a lot of noise in the annotations, and that leads to potentially requiring more data and things like that. So the question is, how do you best get data sets, especially from multi-institutional, from multi-raters? Crowdsourcing is one way. The RSNA has done this successfully by making data available to a lot of raters and having them rated. And typically the challenges are, the test data of the challenges uses multi-rater annotations. Another question that we all are concerned about is that these AI is not just learning our biases, it's amplifying them. We've seen that in a variety of cases in the healthcare domain, besides of other things like facial recognition. There's a lot of bias that's been found. And this bias can take many forms. It can be different populations. When you're talking about the bias in this particular case, it can be Inpatient versus outpatient performance may be different, and we've definitely seen that reported. Disease differences. We do work in ophthalmology again, and we look at Caucasian babies versus Indian babies, and the fundus and the colors are quite different. So an algorithm trained in one population may not generalize to a different population, and we really have to think carefully about how do we set up the algorithm in order to be able to assess that. Some algorithms, again, the BMI might matter, different acquisitions. On the other hand, it has been argued that just as we need to be very careful about the questions of the ethics and bias of deploying algorithms that may be not work well in all subpopulations, one could also argue that maybe it's not ethical to not allow the access, especially in low resource setting. So if we do have access to a suite of tools, and that's can be deployed more broadly, especially for some parts of the world, maybe we should be thinking about things like that as well. Here's our own data looking at the same breast density data. And what we see again is that the breast density algorithm performance is very different in different subpopulations. So it works, this particular algorithm worked really well on the Asian populations. It did not work nearly as well as the Hispanic or Latino populations. And that is something that we need to think about assessing continually. So we cannot just assume that the algorithm, because it's been sort of approved, is going to work as well for all subpopulations. And we need to think about auditing these algorithms throughout the life cycle as they're deployed and continuing to see how well they work. The question of explainability and interpretability keeps coming up. A lot of the deep learning algorithms have been reported as being black boxes, and so one doesn't really know what's causing them to make the decisions that they are making. Some people argue that simpler models such as linear regression is better because it's much more explainable. Other people argue that that's a trade-off between model explainability and model performance, and maybe we should try to see how we can improve that. There's a really good review paper that came out recently on looking at explainability questions and looking at things like post hoc methods such as saliency maps that are so popular in the literature. GradCam is something we see published a lot. There's a number of other methods as well that are used in the literature. Gradient-based saliency maps are very common again. And you really would be hard-pressed to find a radiology publication that does not have some kind of a heat map or a saliency map. However, there's a lot of concerns about, are they useful, are they robust? And so here's some work that came out a while ago, and it's been continuously updated, looking at different saliency map methods, comparing them to, for instance, edge detectors, and showing that essentially some of these methods really fail what they call a sanity check. So for instance, if you take a network and randomize the weights from the top to the bottom, you really hope that the saliency map changes, because one would hope that a saliency map from a trained network looks different than a saliency map from an untrained network. And they look at it in two ways. They randomize the weights of the network and show that in some methods, the saliency map does not seem to change. In another way, they take a trained model on true labels versus a trained model on random labels, and again show that the saliency map does not change. So these things sort of lead you to question the utility of some of these methods, and are they really being used in the way that clinicians tend to use them? So these methods can be useful in trying to understand from a network perspective what it is about the image that may lead it to a discussion, to a certain decision. But the concern we have is clinicians often use them to guide clinical decision making, and sort of making clinical assumptions about that can be somewhat suspect. So this is an area that I think we need as a community a lot of work between the clinicians and the computer scientists to really understand what these methods are doing, what are they saying, what does it mean, and how do we really think about these post hoc methods. Here's a workshop that was held at the McKay conference a while ago, where they had essentially this really nice website that does not seem to be up to date, but essentially what they showed is the saliency maps for this particular case, which is cardiomegaly, Many different saliency maps really do not pick up anything that one would think is relevant to the clinical decision making. They often pick up things like markers. In this particular case, again, as a clinician, I've asked this of many of my clinician colleagues, would this saliency map be of any value to you? And typically the answer is not really. Another thing is, this is another recent work that's on medRxiv, where a lot of what we see is sometimes these methods are picking up what they call shortcuts. And so that might be things that are the easy answers for the network to pick up, but not really the clinically useful question. So we've been proposing a framework to think about how to think about these methods. So if you're going to use saliency map for localizers, maybe compare that with a data set where you have localization. So for instance, on the pneumonia detection data set where you have a bounding box, how often is the saliency map actually picking up the clinically relevant area? And what we find is really very often it is not. It is, although people like to put these pretty pictures in their manuscripts, and we all do that, where if you do a comprehensive, rigorous study, quantifying how often these saliency maps are actually highlighting the clinically relevant area, we'll often find that that's not the case. This has at least been our experience. I really welcome a lot of the field doing these sorts of more rigorous studies a lot more. The question of the sanity checks, where you can randomize the models, you can look at untrained versus trained model, and we hope that it changes, but if it doesn't, then that's a concern. What we see is these maps can be not repeatable or reproducible. So slightly different iterations of the same model with different seeds can give completely different looking saliency maps, or a different network architecture gives a different saliency map. And then the question is, what is it that you're really thinking? What is it that you want this to do? So if you think about framing the clinical problem, you can do it in the same problem can be framed in a set of different ways. So for instance, you can look at it in terms of pneumothorax. You can look at it and say, does this patient have a pneumothorax? Yes or no? Where is the so you can frame it as a classification problem, a detection problem, or a segmentation problem. And inherently, some of these are more explainable and interpretable than others. In the case of a segmentation, you can look at the segmentation and see very quickly, assess whether it is correct or not. In terms of a detection, you can look at the bounding box and see if it's highlighted the area of interest or not. But the classification methods where you then use post hoc can be quite challenging in terms of trying to make sense of what they are. So a suggestion as a community to think about building models that might have some face validity, easier to assess in a sense. Uncertainty is something that was brought up. These models typically don't provide some sense of uncertainty, but there's a number of methods we can use where we can say, these are the cases where the model is least sure about, and so maybe have the clinicians look at that more. And finally, we think about getting these into the clinical workflow. So very often what we have is, we have a retrospective single lab that's developed a model. How do we then go on to the next stage of potentially in a shadow mode, looking at how well these work for real with that? Because obviously there's a lot of regulatory concerns about deploying these models into the hands of clinicians unless they're approved either through whatever regulatory requirements. And then can we do prospective validation? So this is sort of a pipeline starting from a single retrospective model to a system-wide prospective deployment. And obviously that's where commercial algorithms typically end up. So some of the challenges that we've seen is, are we solving the correct problem? Are we solving it the correct way? Do we have the infrastructure? These models may be brittle. What are the regulations? The first two are something that at least we have found to be really important questions, and where we need to have continued discussions between the computer scientists and the clinicians at all times, right? Where it's very often as a computer scientist and as a technical person, we may want to solve the problem that's easy to solve, but then when we bring it to our clinicians, they tell us, this is completely useless. This is not what we want help with. Can you help us solve this other problem? And so this dialogue is really, really key. Here's an example of some work we did with COVID, because obviously we're in the midst of a pandemic. What can we try to do to help this, help in our institution? So our question was, who's going to decompensate essentially? And typically what we see, this was mentioned before in the radiology report, there's no standardization, there's no measure of, there's not much structure, and there's a lot of inter-rater variability. So building these sort of standardized reporting systems might have clinical utility. And so based on the Rails type of scale, where we are essentially looking at severity of lung disease, we developed an algorithm to do that, that can help essentially assess how severe the involvement of the lung is. And based on that, we can see that the odds ratios for predicting who's going to be intubated or not is quite significant. And then we can sort of deploy this, and we have done this in our institution in a shadow mode. So the clinicians don't get the data, it's not presented to them yet, but we can do a lot of research in terms of that. So briefly, some of the challenges are that we need lots and lots of data for deep learning. So certainly public repositories, challenges, crowdsourcing help with that. Models can be biased, so we really need to examine the data and the models very, very carefully, making sure that they work for all subpopulations. These models can be brittle. We need to figure out how to do external validation, and whether that's through federated, rather distributed validation, where you send your data outside your institution, or you allow through things like the ACR's AI lab, your model to be tested elsewhere. All of these things are really help build trust that the algorithm is going to work as well in the settings outside of what it was trained on. Patient data obviously hard to share, so federated and distributed learning is important. Annotations are difficult to acquire, and so maybe crowdsourcing, like the RSNA has been so successful, is one way to do it. Annotations can be biased, so we need to have multiple annotations per case, and then the algorithms themselves we need to think about. There's different ways of training them. So just some final thoughts is that obviously we see so much great potential, but we really need to focus on the collaboration between the clinicians and the computer scientists. And would like to thank my lab and all of our funding agencies. So thank you.